slide. The other slides.
Sounds good. Hey, Kevin, my name's Yusuf. And they brought this pointer for me.
Oh, awesome.
So this one's gonna be laser. This one on the left and right.
Great.
Yep.
Thank you, everybody. Thank you for coming to our session on comprehensive care of the patient with ILD. We'll be discussing the ILD bundle today. I'm Patricia George. I'm the chair of this session. And so, as we all know, interstitial lung disease is a very complicated disease, and patients not only suffer from their getting the appropriate diagnosis and medical treatment, but also various comorbidities. And there have been studies that show that bundled care, i.e. checklists, and making sure that we attack multiple aspects of the ILD patient's health, improves survival. So today we're going to be talking about our ILD bundle, and I'll introduce our speakers right now. So Dr. Kevin Gibson will give the first talk, giving an overview of medical therapies in ILD, and then Dr. Wakwaya will give a discussion about treating GERD and idiopathic pulmonary fibrosis. I'll then talk about pulmonary hypertension, and Dr. Lindell will finish at the end with the role of palliative care in ILD. So with that, Dr. Gibson.
I better learn to walk fast. I only have 12 minutes. I should start out by saying that the title of the talk that I had gotten in the mail, oops, that doesn't work. Let's try something different. Oh, no. Oh, up here. Okay, escape. And then, oh, just click up here. I got you. Oh, okay, the old-fashioned way there. Waiting for agent. Initial evaluation of ILD is an IPF autoimmune or chronic HP. To which I said, in 12 minutes, you got to be kidding. So I'm going to talk fast because I do have a slide that talks about therapy of ILD, but appropriately, it's only one slide. So I like to always begin my talk about ILD and IPF by bringing to memory Averell Abraham Lebo, who many of you probably, there are a few gray hairs in the audience, so some of you do remember this fellow. He was a pathologist, and he's credited with really founding this notion that interstitial lung diseases represent a broad category of diseases that have very unique histopathological features, and that these histopathological features may provide clues as to the etiology, pathogenesis, natural history, and prognosis of disease. And this is what led to the idiopathic interstitial pneumonia classification, largely because of his work and the work of people that he trained and followed. And the reason why I introduced Averell is to emphasize the importance of pathology in this disease, which we get less and less of. But this is a slide taken from an image from the 2011 guidelines from the ATS. And it reminds us that the histopathological features of IPF are important in establishing the diagnosis, and it's been, we're getting much better at defining these histological features. So pathologists today recognize that this is a diagnosis that you make at low power microscope. It has a temporal heterogeneous distribution of injury with subpleural fibrosis, fibroblastic foci, and evidence of lung remodeling. But it really wasn't until about, say, 1995, 1997 or so that we began to recognize that CT scans are probably equally valuable in making the diagnosis, because there are CT scan findings that correlate strongly with the histopathology of usual interstitial pneumonia. And I show this slide to emphasize that the importance of obtaining high-resolution imagery in order to see these histopathological changes. So the diagnosis of idiopathic pulmonary fibrosis over the last, say, 5 to 8 years has really emphasized these radiographic findings. And the radiographic findings are sort of summarized in this slide. This is an adaptation of a table from the 2011 criteria that were published. I like the table better, so I just made some changes to conform to the 2018 guidelines, which are not much different. But the typical UIP pattern should have the 4 classic features of subpleural predominant changes with reticular abnormalities, honeycombing with traction bronchiectasis, and the absence of features that are thought to be inconsistent with the diagnosis. What's changed in the most recent classification is to move from possible UIP to probable UIP, recognizing that if you just have this subpleural predominant disease with reticular abnormality in the absence of other features, that you probably are dealing with a usual interstitial pneumonia pattern of scarring. But there are patterns on CT scan that are thought to be inconsistent with UIP, although it doesn't exclude the diagnosis, and I'll point this out as we talk a little bit more about the criteria. Upper or mid-lobe predominance, peribronchiovascular predominance, extensive ground glass abnormalities, profuse micronodules, discrete disc, diffuse mosaic attenuation, and consolidation in bronchopulmonary segments are thought to be inconsistent with the UIP diagnosis, at least radiographically. But the most recent criteria does combine these two features, and I guess I do have a pointer, don't I? Let me make sure that I point. Oh, good. And as we'll learn from the criteria, if you have an HRCT scan pattern that's consistent with UIP, you really don't need histopathology. But I'd like to move along the indeterminate line to show that we can make the diagnosis of UIP based on CT scan if we have an indeterminate UIP pattern histopathologically and an indeterminate HRCT scan, recognizing that with a multidisciplinary conference, if we have clinical features that strongly suggest a diagnosis, that oftentimes we're going to be right on the mark. And so I think there's a softening of the importance of HRCT scan in the current criteria, and an increased recognition of the fact that histopathology and clinical features are increasingly important in making this diagnosis. What I really like about the most recent criteria, though, is they've taken a stand on certain things that I think were important because it doesn't conform to what we do in clinical practice, and that is to say that a patient that has a definitive UIP pattern on HRCT scan does not need a BAL, does not necessarily need a surgical lung biopsy. There's no need for transbronchial lung biopsies. There's no need for lung cryobiopsies. And biomarkers, while it's a favorite topic of mine, are probably play a little role, at least in evaluating those patients. However, if you have patients that you suspect have IPF based on CT scan findings, that they suggest, although there was not a conformity with regard to these suggestions, possible analysis of BAL, possible surgical lung biopsy. I think there's a role for that in some patients. There was no recommendation for or against transbronchial biopsy or cryobiopsy in the most recent guidelines. So I think that was sort of conforms with our current practice. And so the algorithm that has been proposed, and I take this from the 2011 recommendations, but modified it to conform with the subtle changes in the most recent recommendations. That is, we start out with a patient in whom we suspect the diagnosis of IPF. We look for identifiable causes for interstitial lung disease, and I'm going to spend a little bit of time talking about that. And then an HRCT scan is performed, and if the pattern is UIP, classic UIP with the four abnormalities we described earlier, then I think we can comfortably establish a diagnosis of IPF, and we're all very comfortable with that notion. However, if it's probable UIP or thought to be inconsistent with UIP, there is a role for surgical lung biopsy. And of course, we have to weigh that against the surgical risks, et cetera. In Europe, we might consider a bronchoalveolar lavage. I think in the States, we do this much less so because of sort of the demise of BAL labs as experimental tools in the United States, but maybe some places do still do this. And then based on the surgical lung biopsy and the CT scan, a multidisciplinary discussion is undertaken, and we'll either arrive at the diagnosis of IPF or establish another cause for their abnormalities. And so the algorithm emphasizes still the role that CT scan plays in decision-making with regard to whether or not to proceed with lung biopsy. But what about secondary causes? What should we look for? And this is a challenge because, probably one of the most interesting of the secondary causes that we struggle with is chronic hypersensitivity pneumonitis. Typically we ask about birds at home, mold exposure, indoor hot tubs, cedarwood exposure, et cetera. But with chronic HP, most of these patients don't have symptoms at the time of exposure. And so at least in our center, and we see a lot of these folks, I would say the most common way that diagnosis is made is it's discovered as a granulomas on an incidental surgical lung biopsy. And then we go back and say, where did that come from? And probably about 50% of the time, we cannot ascribe an etiology for their chronic HP, at least in our experience. But it's not the experience that's been published elsewhere. So Moises-Selman, for example, in Mexico is very good at identifying the fact that, in Quintana Roo provinces in southern Mexico, people love their birds, and so bird fanciers disease is very common. There was a publication that described, at least in India, that about 80% of patients that were thought to have UIP on surgical lung biopsy were found to have, or at least by other tools, were found to have evidence of chronic HP. And in Spain, there was a publication, I believe, that suggested that about 40% of patients in one study was thought to have HP as etiology for their IPF. So there are, I think, seemingly, although these are limited studies, seemingly wide differences in the distribution of HP, and probably there's lots of geographic variation. Autoimmune diseases are important. This was emphasized in the most recent recommendations, although the degree to which it is explored, there was no consensus of opinion as to how far you should go. So we tend to look for everything because we're a referral center that has an interest in autoimmune lung disease. But dermatomyositis and polymyositis, particularly if it's amyopathic, will very often end up in your office first with the diagnosis of presumptive IPF. And if you're not careful in exploring for these diseases, you'll miss that. The vasculitides are important, as well as lupus, systemic sclerosis. Probably systemic sclerosis is more important than lupus, Sjogren's syndrome, et cetera. Industrial exposures in the Pittsburgh area is also important for us. Toluene diisocyanates are actually quite a common exposure, and I have several patients that actually have HP related to toluene diisocyanates, which reminds me to say that one of the nice things that I think came out of the most recent recommendations from the ATS is to diminish the value of the HPF, the hypersensitivity pneumonitis panel screen, because most of the diseases that we look for are not included in that panel, and it's probably never really been rigorously tested as a useful tool for evaluating HP patients. So we've never ordered that panel, and I think the statement in the current guidelines sort of underemphasizes that. Drugs, of course, are also important in radiation-induced lung injury. So just a moment about hypersensitivity pneumonitis, and I think that this deserves maybe a few comments. It is a form of lung disease that obviously involves lung inflammation, probably as a consequence of inhalation of a bacterial fungal antigen, although industrial exposures can also lead to this disease. And what makes it challenging for us is the easy ones are bird fanciers and lab workers. We can always get that in the history. But what we can't often get in the history are the other causes. Unventilated shower, humidifier lung disease. I mean, these are diagnoses that are very difficult to make preclinically. And often we discover these patients after they get a surgical lung biopsy that shows granulomas, and then you go back and get the history and figure out what's going on with regard to their etiologies. In terms of autoimmunity and UIP, one of the things that came out of the most recent recommendations is that there was no general agreement on which tests to perform in that consensus statement. And I think there is a recognition, at least, that this is an important category of diseases to look at, because the prognosis can be dramatically changed if it turns out that they have an autoimmune background to their disease in most cases. And so looking for the antisynthethases, the ones that are most important are JO1, PL7, PL12, OJ, EJ. MDI5 is especially important because this is associated with very rapidly progressive disease, as well as anti-KS. Anti-KS is interesting in that this particular antisynthetase, which is an asparagine tRNA synthetase, does not appear in most myositis panels. It's only detectable, I think, by immunodiffusion and immunoprecipitation. But it is an important cause of UIP. And so it's one of the reasons why we prefer immunoprecipitation techniques to evaluate for these particular proteins. Important to state that all of them can be amyopathic, so these folks won't come to you from a rheumatologist. They'll come to you because they have respiratory symptoms. And the same is true for the non-DM-associated autoimmune diseases. So, for example, for scleroderma, anti-CoO, PMSCL, THTO, and SCL70 are all important biomarkers for these diseases, as well as SM and RMP, Rowe and Law, ANCA. All of these disease manifestations can be present as interstitial lung disease is their primary initial presentation. And so we believe it's a strong argument for looking for all of these to make sure that the patient doesn't have an autoimmune background, which dramatically changes their prognosis, particularly if they're treated for that autoimmune disease. So what about therapy? This is what I'm supposed to spend the next 12 minutes on. Well, my one slide. We're all familiar with these studies. We've seen them before. The nintedanib trial, I like the composite data because it, with regard to nintedanib, it combines both TOMORROW and IMPULSIVE trial. TOMORROW, as you remember, was a phase 2 trial that was conducted primarily in Europe, had about a 30% dropout rate, so none of the endpoints reached statistical significance, but it was published in a very nice journal. Ricaldi combined that with IMPULSIVE's data, which is the 2 phase 3 clinical trials, to show that if you treat patients with nintedanib, that you can achieve about 111% reduction in decline in lung function over a period of 52 weeks. Likewise, with pirfenidone, this data is combined, Paul Noble combined the capacity data. You'll recall the capacity 1 and 2 trials were done, only capacity 1, I believe, reached its primary endpoint, and so ASCEND was done to give them 2 phase 3 clinical trials that would get them FDA approval. But nonetheless, when this data was combined, again, with pirfenidone, we saw about 150 cc reduction in decline over a 52-week period. And the big question, of course, with therapy is, who should we treat? And I think we're all learning how to use these drugs because they have side effects, and patients who are doing well and have no symptoms are probably not going to be very receptive to therapy. And so that's the data, but I want to end this with an audience participation question. And unfortunately, you don't have clickers, and so I'm going to go by a show of hands. And if you don't show your hand, I'm going to call on you. Okay? So question number 1, and I'm interested in your opinion about this. A 55-year-old man with definite UIP on HRCT scan, progressive disease, based on CT scan, pulmonary function, and symptoms. He has blood work that showed a positive AMA and an MPL distribution with no clinical evidence of vasculitis. What would you do? How many would do a surgical lung biopsy? 1. How many would do transbronchial biopsy and BAL? Okay. Closely observe with no intervention? Initiate immunosuppression with azathioprine. Wow. You're kind of thinking like me. Where's the data? There is none. But you know, there's a rationale, and the rationale is that if this is an autoimmune lung disease and they're progressing, we want to do something. And so I think that's a compelling rationale. Hopefully data will come out of Japan soon because they really are the leaders in understanding this conundrum we face with vasculitis. Question number 2, 57-year-old female with classic HRCT findings, evidence of stable disease over 24 months. She has mild GERD, Raynaud's phenomena, and laboratory testing that shows a positive THTO. What would you do next? How many would do an echocardiogram? How many would initiate therapy with mycophenolate? 1. How many would initiate therapy with azathioprine? None. Surgical lung biopsy. Sounds like everybody is backing away from this one here. Well, it turns out that THTO is obviously a marker for scleroderma. So this person has scleroderma. And typically, THTO-positive patients have a slightly higher risk of developing pulmonary hypertension. So they behave very much like systemic sclerosis with limited cutaneous involvement. So an echocardiogram is probably a reasonable course of action in that patient. Question number 3, 51-year-old with slowly progressive IPF based on CT scans, PFTs, and CT scan, symptoms rather. She denies Zika symptoms, but her laboratory findings did show a low C4. She had hypergammaglobulinemia, a positive rheumatoid factor, and a normal SSA and SSB autoantibodies. What would you recommend? A, referral to ophthalmology for salivary gland biopsy? No one? Okay. Initiate antifibrotic therapy with pirfenidone and nintedanib? Come on, no guts, no glory, guys. High-dose corticosteroids. Bronchoscopy or bronchoalveolar lavage? No one, huh? Referral to rheumatology. So it turns out that you should have a high suspicion for Sjogren's. even with a low SSA and SSB, probably less than 50, more than less than 50% of patients with Sjogren's will have positive Sjogren's antibodies. But the clue is a low C4, hypergammaglobulinemia, and a positive rheumatoid factor. And so we try to accumulate evidence for Sjogren's based on these biopsies. And I emphasize this because increasingly, these rheumatologic problems are being dumped in the lap of our pulmonologists because guess what? They don't have rheumatologic symptoms. They only have progressive lung disease. And so it's increasingly part of our responsibility to kind of help negotiate this. And we have no data. End of talk. Thank you.
All right, so my name's Joseph, and I'm going to be talking about GERD and ILD, and because I feel like most of the emphasis in the literature is on IPF and GERD, and I only have 12 minutes, we'll kind of just stick to that for today. So I have no disclosures at this point in time, and then so for our learning objectives at the end of this, I want to be able to understand how reflux may play a role in IPF, know how reflux is unique in IPF, and then also review our gaps in knowledge about reflux and IPF. So we're going to start out with this case, and then we'll kind of get back to it here at the end. So there's a 75-year-old male who has IPF. He's a former smoker. He's on Esbriet. His FVC is declining a little bit quicker than you would like. He denies any symptoms of reflux, no heartburn, regurgitation. Should you do further workup to evaluate for GERD in this patient? And so first off, we're going to talk and define what is gastroesophageal reflux and what I'll sometimes refer to as GERD. So it is reflux of gastric contents into the esophagus. We usually divide it into two groups. One of them is acidic, which is a pH less than 4, and then in GI literature, they also call it weakly acidic or non-acidic when the pH is greater than 4. The contents of reflux is not well described. We know that it has acid, pepsin, trypsin, other enzymes, bile acids in there also, food particles, and even occasionally bacteria. GERD is when reflux becomes symptomatic. So that's going to be heartburn, regurgitation, cough. And then you can confirm acidic reflux by a 24-hour pH probe. And then with impedance testing, you can diagnose either acidic or weakly acidic reflux. So reflux itself is not of concern. It's when reflux becomes microaspiration that we're concerned in idiopathic pulmonary fibrosis. And so we know IPF is a progressive fibrosing interstitial pneumonia of unclear etiology. The strongest risk factor that we have for it is aging, and that probably leads to some genomic instability with telomere attrition, epigenetic alterations. And then there's also some individuals who have a genetic predisposition with things being discovered like MUC5B that leads to altered fibrosis in response to epithelial injury. But over time, there needs to be recurrent epithelial injury. There's a high prevalence of smoking in patients with IPF, so we think that that could represent a source of that. But the other is possible microaspiration in patients who have GERD. And so here you can see in the diagram, the reflux enters the esophagus, and then it can go all the way up to the oropharynx, which is sometimes how you get that sour taste if you've ever experienced reflux yourself. But part of that volume that reaches up there and goes past the upper esophageal sphincter can slide underneath the epiglottis down into the lungs. That would explain the basilar predominance of IPF and also be a little bit consistent with the temporal heterogeneity we see on pathology with fibrosis. And it's important to note that we don't know which part of the refluxate we're concerned about with this. Chen et al. Initially looked at aspiration of gastric contents into mice models, and they found that pH was not really related to the development of fibrosis. They were able to just instill bile acids that led to fibrosis. Here in this chart, on the x-axis, you see different groups. The NC is the healthy control, and then each individual group after that is a separate bile acid. And on the y-axis, you see a score of fibrosis. And at the end of 7 weeks, there is significantly more collagen deposition and architectural distortion in those rats that received intratracheal instillations of bile acids. They also had increased expressions of fibrogenic cytokines such as transforming growth factor beta. But, those are rats. Who cares? What about humans? In humans, GERD usually only has a prevalence of about 20 to 30% in the normal population. But it's been described in IPF as high as 87 to 94%. And what's even more unique is how many people don't have symptoms, meaning that we may be missing a significant portion of our patients that have GER. Multiple studies have described less than half of patients being symptomatic from their reflux. And so this is my favorite prospective observational study of GER in IPF patients. And so in each cluster, the white is going to be IPF, light gray is non-IPF ILD, and the dark gray is healthy controls. And then in the first cluster, total reflux on the x-axis, and then acidic and weakly acidic reflux. And on the y-axis, what you see is number of reflux events. And in all of these, IPF had significantly more reflux than compared to even the non-IPF ILD group, indicating that perhaps they're more intimately tied than other fibrosing pneumonias. Also from this study, they also had more proximal reflux, and then there was a correlation between total reflux and proximal reflux with their net fibrosis score on high-resolution chest CT. A subset of these patients also underwent bronchoscopy and had BAL, pepsin, and bile acid levels, which correlated with their net fibrosis score that was not seen in non-IPF ILD or the healthy volunteers. Again, indicating that perhaps GERD, which is more frequent, may be leading to some microaspiration and is correlating with the net fibrosis score. So what about the clinical outcomes? Because that's what really matters, right? We just want people to be better and feel better. So some data suggest therapy attenuates decline in FVC. Here on the y-axis, what you're going to see is forced vital capacity in liters, and on the x-axis is time in weeks. And this was published by Joyce Lee. She took the placebo arm of 3 randomized controlled trials and looked at who was on PPI and who was not on PPI. And what you can see is the blue line is those on therapy for antacid therapy. They had an attenuated decline in their FVC both at 30 weeks and then again at 52 weeks. And also, these patients had less exacerbations when compared to the no antacid reflux therapy group. However, the data are conflicting. This was a repeat study that had a similar design than the one published by Joyce Lee and was published in The Lancet just a couple of years ago. In a different 3 prospective randomized controlled trials, they took the placebo arm of those IPF patients and looked at who was on anti-reflux therapy and who was not. Here, their primary outcome was looking at a composite endpoint of either death, FVC decreased by 10%, or a change in their 6-minute walk distance by more than 50 meters. And there was no significant difference in this group. Also, in patients who had an FVC less than 70%, they found an increased incidence of pulmonary and non-pulmonary infections on those who were on PPI. And so the only prospective data that I have to show you looking at anti-reflux therapy in IPF patients was recently published this year, the RAP-IPF trial. And so what you see here on the y-axis is going to be change in forced vital capacity, again, in liters, and then on the x-axis is weeks. And so the top line is those who underwent surgery, and then the bottom line that had a quicker decline, but non-significantly so, is those who ended up receiving no surgery. And so this was a phase 2 study. It was only to look at efficacy. They did not have the number enrolled to maintain or to prove efficacy of this in maintaining FVC in IPF patients. So what treatments can you do? Lifestyle modifications are cheap and not harmful. A systematic review shows that symptoms are improved only by head of bed elevation or weight loss. Also, what we think from what we know is that the primary indicator for the lower esophageal sphincter to relax is distension in the stomach. So fasting prior to laying down before bed is also important. Medications, the only things that we have is targeted towards acidic reflux, and then surgery, there's fundoplication, but its usefulness in IPF is not clear yet. So the only international guidelines that we have that look at this is from the ATS, ERS, and then JRS. And what they say is, hey, we think you should use regular antacid therapy for patients with IPF. But there's a big asterisk in that because there's very low confidence in estimates of effect. Only Joyce's data that was positive had been published at the time of this coming out. Since then, studies looking at patients on antifibrotics and PPIs really haven't shown a lot of benefit. So it's up in the air. So just to review the gaps in our knowledge that we have right now. So I can't tell you today if reflux is pathological in IPF yet. I can't tell you if reflux is leading to fibrosis or if fibrosis alters the esophageal mechanics in the thorax and that leads to increased reflux. I also can't tell you what part of reflux we should be concerned about. And then I can't tell you definitively if antacid therapy or surgery will improve clinical outcomes. So what about our patient? He denies heartburn and regurgitation. But like I had said earlier, less than half of these patients are symptomatic. So I would implore you to consider PPI therapy in these patients. Although the benefit is unclear, it just seems like that there is minimal risk from doing it. At our own institution, in our workroom, we have a myriad kind of approach to this. Some people just offer PPI. Some people want to do impedance testing or 24-hour probe. But because it does not lead to anything past an optional PPI, I myself just do a shared decision-making conversation with the patient and be like, would you like to add on an additional pill? We're unsure. Here are the risks and the benefits. So just to look at the review of what we've said is reflux may lead to microaspiration, and that could be a source of this recurrent alveolar epithelial injury. Intratracheal installations of gastric contents, and even just limited to bile acids, can lead to fibrosis in mouse models. IPF patients appear to reflux more than non-IPF ILD in healthy controls. GERD symptoms have low sensitivity and specificity in IPF patients. And then antacid therapy may provide benefit, but the data are conflicting. And then these are a couple of papers that I would recommend. The top one is a great summary in the state of GER and IPF. And then the bottom one is, again, the only prospective data that we have, which is the RAP IPF. Thank you.
Thank you. All right. So on to our third section. So I have the pleasure of talking with you about pulmonary hypertension. All right. So our patients climb virtual mountains with interstitial lung disease. Similar to if you're hiking or you're biking, they have to overcome obstacles. And I believe it's our job as participants in this multidisciplinary approach to help them overcome each obstacle. And in my case, I try to help them with possible pulmonary vascular disease. So I'll start out with first take-home messages. So if you leave this talk, know that number one, pulmonary hypertension is common in ILD and is associated with increased mortality. Identifying pH, I believe, is critical to helping understand a patient's prognosis and triggering referral for lung transplantation or to a pH specialty center. First-line therapy in treating pH and ILD, as I think most of us know, is treating the underlying lung disease and hypoxemia. And treating pH and ILD is difficult and really depends first on careful phenotyping of the lung disease and concomitant pH at a specialty center, and we need a lot more studies. So before I go any further, just a quick definition. You'll hear me use the word WHO Group 3 pH, which is World Health Organization Group 3 pulmonary hypertension. It's defined as precapillary pulmonary hypertension, meaning a mean pulmonary artery pressure on cath of 25 or greater, a wedge of 15 or less, and a PVR, pulmonary vascular resistance, of greater than 3, and concomitant lung disease. And this can be COPD emphysema, alveolar hypoventilation, chronic hypoxemia, and of course, in this talk, we'll be talking about interstitial lung disease. So pulmonary hypertension is actually really common in ILD. In this systematic review, you see these prevalences all over the map. This is looking at the prevalence of pH in ILD, but it's various definitions. It could be echo in one study, symptoms in another, right heart cath in another, with or without wedge pressure, et cetera. If we go ahead and just look at the studies that used precapillary pulmonary hypertension, the prevalence reported in these studies was between 29 and 43% of ILD patients. That's over a quarter to over a third of ILD patients may have pH. And if you have PH and IPF, it definitely affects prognosis. So in a study of 79 IPF patients being evaluated for lung transplant, if their mean pulmonary artery pressure was 25 or greater, their 1-year mortality was 28% versus 5.5% in those without. In another study looking at pulmonary hypertension defined by echocardiogram, those with severe PH, defined as a PASP of greater than 50, had a median survival of less than 1 year. So hemodynamic risk factors also predict death. So when you actually look and do a right heart catheterization, you can find some pretty significant risk factors, and namely PVR. So in one study of 66 patients with diffuse parenchymal lung disease who underwent right heart cath either for suspected PH or lung transplant eval, those who had a PVR of at least 6.23 Wood units had an 8-fold increased risk of death at 1 year. If you had significant RV dilation on echo, it was a 4-fold increased risk. And interestingly, in this cohort, age, pulmonary function, RVSP, they didn't predict 1-year mortality. Biomarkers can also be associated with worse outcomes. In a couple of studies looking at BNP and echocardiogram, one study showed that there was increased mortality in patients with an elevated BNP, not remarkably elevated, greater than 70 in terms of what we use in the US, or if they had moderate to severe PH by echocardiogram, they certainly had worse survival. And another one of open lung biopsy confirmed IPF patients who had a BNP measured within 3 days of their echocardiogram. If both the BNP and the PSP were elevated, they had the worst outcome. If neither were elevated, they had the best outcome. And if either one, they fell in the middle on those survival curves on the bottom. So how do we slay this dragon, this crested butte? How do we approach PH and ILD? Well, if you look at the 2015 ERS guidelines, they give us various recommendations. And I put in bold the most important one that I'm about to talk about, which is that use of drugs that are approved for pulmonary arterial hypertension are not recommended for patients with PH due to lung disease. So we sort of find ourselves in a balancing act. So the World Symposium of Pulmonary Hypertension meets every 5 years, and we rediscuss how we classify lung disease. And in 2013, so back in the day, you may have heard, and people still use the terminology, by the way, of disproportionate pH or out of proportion pH. And in 2013 at that meeting, they changed that to really try to break out into this chart. Where's the pointer thingy? Ah, there. To try to break out into this chart the concept of, I might not be able to make this work. Oh, there it is. Okay. I just can't see. To break out the concept of mild to moderate and severe lung disease and no or mild, moderate, severe pulmonary hypertension. So to walk you through this table, if you have a patient who has mild lung disease up here in this corner, which would be IPF with a FVC of greater than 70% predicted, minimal findings on CT scan, that would be considered mild lung disease. And if their MPAP is less than 25, they don't have pulmonary hypertension, so they don't recommend drugs. If they have severe pulmonary fibrosis, again, no pH drugs are recommended. When you get into the moderate and the severe pulmonary hypertension, things may change a little bit, although we still do not have recommended therapies for these diseases. But you could have someone with mild pulmonary hypertension, and I can walk you all the way over here to mild lung disease, and walk you all the way over here to severe pulmonary hypertension. And that begs a question. So if you have someone with a mean pulmonary artery pressure that's extremely high and very minimal lung disease, the question for us is, do they really have group 3 disease, or is it more of an arterial PAH phenotype? And the answer is unclear. Of course, if somebody has severe lung disease and severe pulmonary hypertension, they should be referred for lung transplant and possibly to a specialty center to develop a very individualized protocol given their extremely poor prognosis. And in all cases, we need more trials. So the Cologne Consortium met this summer, and they meet regularly as well, and they defined severe pulmonary hypertension in interstitial or in lung disease as meeting at least 2 of those criteria, those being a mean pulmonary artery pressure of greater than 35 or greater than 25 with a cardiac index below 2, or a pulmonary vascular resistance of 6 Wood units. So they had to have 2 of the 3. And the idea behind that is they really want to target severe PH as being those patients that have an elevated pulmonary vascular resistance, arterial disease, because that's what we saw on that previous mortality data. So I could go through this, and I will go through this real quickly, because these are all the clinical trials summarized in a table that have not shown benefit of ERAs, endothelin receptor antagonists, in patients with interstitial lung disease, and in fact, increased disease progression and hospitalization with one of those drugs. We have a little bit of a different story when we talk about sildenafil being used in idiopathic pulmonary fibrosis. In the STEP IPF trial, they didn't meet their primary endpoint, but in that trial and in the STEP IPF sub-study, they did show that patients did have an improved exercise tolerance and less of a decline in their 6-minute walk distance, especially seen if they had right ventricular systolic dysfunction or right ventricular hypertrophy. And most recently, we had the RISE IIP trial that was riociguat or Adempas used in these patients, and it was terminated early due to severe adverse events and mortality in the riociguat arm. So the RCTs aren't really helping us much here, with the caveat perhaps sildenafil is helpful. But if we go to single-center trials and real-world experience, we might be able to glean some ideas. And one is the study by Sagar, where they actually used sub-Q and IV treprostinil parenteral therapy in patients with IPF and severe pulmonary hypertension. And they measured hemodynamics and PFTs at the beginning, and then at 12 weeks later, and put all of their patients, it was an open label study, put all of the patients on medications. And what they saw was that they all had significant benefit in every hemodynamic profile. Their PVR was significantly reduced. Everything on the right heart cath improved. Their 6-minute walk distance significantly improved. Their quality of life measures improved. And what's interesting is the pulmonary function tests and oxygenation did not differ at 12 weeks. So looking again at real-world use of PH therapies in ILD patients, I'll point you toward the COMPARA registry, which is 7 European countries plus Australia and Japan. And people enter this registry when they're put on vasodilator therapy. So this is everybody's on vasodilators. And they did a study looking at PH-ILD versus IPAH patients to see what the differences were and how they responded to therapy, et cetera. And what's interesting is, what you'll see in that chart is, well, first off, the PH-ILD patients that entered the trial were much sicker. They were NYHA functional class 4, much sicker than the IPAH patients. Regardless, both groups, IPAH and PH-ILD, had about the same improvement in their 6-minute walk distance at follow-up, as well as change in their NYHA functional class. But what you can see from that mortality curve is that there's extremely poor survival in the PH-ILD group, IPF group, compared to the IPAH patients. And we can splice that out a little further and look at responders versus non-responders in the PH-ILD group, and there's a slight signal that there was an improved survival in patients who actually responded to vasodilator therapy. And another study is a retrospective study looking back at all of the WHO group patients in this one cohort by Lang and colleagues. And they looked at who was treated, who wasn't treated, and found 40 patients with severe PH, MPAP of greater than 35. And what they found was that those who were treated actually had a much improved survival than those not treated. And it's interesting because it was the sicker PH patients in that treated cohort, which argues that perhaps this is just a different disease than just baseline group 3 PH, and that they actually responded to therapy. But when you see a 75% 5-year survival versus a 19%, it argues for trying to phenotype these patients better. So in our experience, we did a retrospective study of 153 patients who were diagnosed with pre-capillary PH by right heart cath, and then also diagnosed with concomitant lung disease. They couldn't be on PH meds at the time of therapy. And what we found was that about 50% of patients were started on therapy, and about 50% of the ILD CPFE, combined pulmonary fibrosis emphysema patients, were started on therapy. And those who were treated were sicker, so they fell into the severe PH cohort with an elevated pulmonary artery pressure, elevated PVR. And the initial therapy was most commonly a PDE5 inhibitor. And what we found was at 1 year of therapy, we were looking for tolerability of the drug, and so at 1 year, 53% of ILD patients remained on therapy. We've just begun to try to tease out biomarker improvements. Again, knowing that these things have prognostic significance in PH-ILD, we were curious, and PH due to lung disease, we were curious. And these are very low numbers, but early data shows a potential signal in improvement in BNP and 6-minute walk test in patients who were treated in our cohort versus those who were not. So summary thus far, I've talked to you and told you that pulmonary hypertension is extremely common in ILD and is associated with increased mortality. that there's no randomized controlled trials that support the routine use of vasodilator therapy and PH-ILD, that there is this concept from World Symposium and again in Cologne of weighing the disease severity of lung disease against the severity of pulmonary vascular disease. And due to this concept of severe PH, there's certainly some real-world experience at PH centers in treating these patients, but it's very complicated, and we need to really focus on trying to tease out better how to treat these patients. So in my last slide, what should you do when you're faced with this patient? So I would argue that patients should get screening echocardiograms, maybe annual routine echocardiograms. But if you with ILD, but especially if you see a patient who's presenting with disproportionate symptoms, increased dyspnea, but their PFTs have been the same, perhaps except for their DLCO. Their CT scan is unchanged, but they're just more symptomatic, get an echo. And there's no time to talk about pros and cons of echocardiogram, but it's our best screening test. So get an echo. And if you see signs of severe PH, defined as elevated RVSP, RV dilation, dysfunction, et cetera, then I would argue to refer to a PH specialty center to further tease out how to evaluate and perhaps develop an individualized treatment plan or enroll in clinical trials. And of course, refer for lung transplant. So patients who have IPF and pulmonary hypertension, that's a criteria for listing for lung transplant. So if they haven't yet been referred, you should be having that conversation if they're eligible. And of course, in all patients, regardless of whether they have PH or not, we definitely have to maximize treatment of the ILD with medications, oxygen, pulmonary rehabilitation, treating the comorbidities, perhaps their GER, and symptom management. So with that, I thank you.
How do I get to the? Yeah, but I want to increase the size.
Oh, it's up there.
Oh, okay. So thank you. My name's Kathy Lindell. My disclosure is that I'm a nurse, and I have worked with patients with interstitial lung disease for probably 25 years. And I'm always concerned that the patients and their caregivers don't really appreciate the magnitude of the disease and the implications. So I'm going to talk to you today about integrating early palliative care for patients with progressive fibrotic interstitial lung disease and their caregivers. So this here in this photo, this is one of our patients. And so Pittsburgh is known for rolling hills. Frank really felt that it was important that he had to cut his grass. So if you take a look at this lawnmower, it's a gas lawnmower, and he has hooked up an E-cylinder. So pretty dangerous, but he survived. And this was a month before his lung transplant, and he's now about 10 months out. So for some background, progressive fibrotic ILD is characterized by progression despite appropriate treatment. Median survival is 3.8 years. The disease progression varies per patient. And patients and caregivers often have difficulty recognizing the disease magnitude. So our goal is to help patients achieve the best quality of life. So in this slide, this is a literature review of recent articles, but it's not exclusive to just these. So progressive fibrotic ILD is associated with a shortened lifespan, variable disease course, tremendous symptom burden, poor quality of life, impact on the caregivers, limited treatment options, need for supplemental oxygen, and a need for palliative care. We did a study at our center where we looked to see where were our patients with IPF dying, and this was published in Chest in 2015. And what we found, we had a total of 868 patients. We had 465 decedents. We excluded lung transplant recipients. And what we were able to find was the known location of death for 277 patients. This involved the Social Security Death Index, reviewing obituaries, doing Google reviews of where patients were. And an important thing to note is sometimes these patients don't come back to you, so you may have only one visit with them and they're lost to follow-up. Now, what we found in this experience, this was from 2001 to 2012, is that diagnosis to death, median survival was 3 years. If you take a look across the x-axis, this is the duration of survival from diagnosis to death in years, and then their cumulative survival. So then we took a look at their first center visit to death in years, and the median length was only 1 year. And so on average, there was a 2-year delay from diagnosis to initial evaluation at the Simmons Center. We did another segment of this study, and what we found was ICU admission happened early. So if you take a look across the x-axis, the first center visit to ICU admission in months, there were 34% of ICU admissions that occurred within 4 months of their first center visit. So they didn't get to come back and have that second visit to have the discussion about the magnitude of the disease. And the median was 9.5 months between the first center visit and the ICU admission. Then this led us to do some focus groups with patients to find out what they knew about palliative care and what their needs were. And the themes that emerged, first of all, we interviewed patients with IPF, caregivers, and caregivers of decedents. And we interviewed all 3 of those groups separately. And 4 themes emerged. They said that there was a need for education. They came to see us, they received no education. Meanwhile, we give them this really nice brochure or folder with all this information. They said they didn't remember getting anything. They also, the symptoms were very impactful, particularly cough in this population, and particularly cough as experienced by the caregivers. Many of these caregivers were still working, and they wouldn't leave the bedroom at night because they didn't want to upset the patient. And they said that the patient would cough through the night, and so that left them with an altered sleep for their work for the next day. The patients and the caregivers did not like the word palliative care. They thought that it was a negative term, and they thought that it was, we were giving up on them, despite that they had overwhelming symptom burden. But they felt very comfortable in the specialty center because of all the resources. So what is palliative care? So this is the World Health Organization description. It's an approach that it improves the quality of life, prevention and relief of suffering, early identification and impeccable assessment and treatment of pain and other problems. And the focus is, if the 2 things that you just have to think about this, is the focus is on symptom management and addressing advanced care planning. So what is hospice? Hospice is provided when the patient is thought to live less than 6 months. The 2 are very different. It focuses on comfort and pain relief, and the patient forgoes aggressive treatment. So palliative care and hospice, if you take a look at this schema, this is from the Center to Advance Palliative Care. Palliative care should be delivered concurrent with treatment. So it should be delivered right when someone is diagnosed with a serious illness. ILD, IPF, these are serious illnesses. Last year, this was published in The Lancet. So this was an international review, palliative care in interstitial lung disease. And if you take a look, might be a little hard, but these are all the things that should be involved. Our whole goal is optimized quality of life. So we want to make sure that the symptoms are addressed, they have the best supportive care, that caregiver is also addressed in their needs, that disease stabilizing care occurs, patient-centered management, and end-of-life care. So in this, I'd like to share this 3-minute video with you. This is available through the Pulmonary Fibrosis Foundation. And hopefully there would be no,
by people living with a serious illness. The goal of palliative care is to optimize your quality of life and prevent suffering. Many people are
Sorry, technical difficulty. Okay.
Palliative care is an approach to managing the symptoms experienced by people living
Sorry,
with a
guys.
serious illness. The goal of palliative care is to optimize your quality of life and prevent suffering. Many people are afraid of the term palliative care. It is often incorrectly compared to hospice, or in some cases, that the clinician is giving up on the patient. This is not an accurate view of palliative care. Palliative care focuses on anticipating, preventing, and treating symptoms to prevent suffering. Palliative care also addresses advanced care planning and improving quality of life. People living with pulmonary fibrosis who experience shortness of breath, cough, fatigue, anxiety, or depression can find relief with palliative care. Addressing advanced care planning puts the patient in charge of what care they want as the disease advances. Making decisions about the care you would want to receive if you become unable to speak for yourself helps caregivers and family members to be aware of what you want. There is a trend towards using the term supportive care instead of the term palliative care. Some call it quality of life care. Recently, we've heard the term comfort care. These terms all mean the same thing: managing your symptoms so that you can achieve your best quality of life. Palliative care is different than hospice care and can begin at diagnosis. It can begin at the same time as any medical treatment, including a lung transplant. Hospice care, on the other hand, focuses on managing your symptoms after a patient is expected to live less than 6 months and aggressive treatments have been stopped. Several studies have shown that providing palliative care improves quality of life and relieves symptoms. In one study, patients with lung cancer who received palliative care lived longer and more comfortably than patients who received standard care from their oncologist. So how do you get palliative care? You should ask for it. Don't wait for your doctor to suggest it. There's a lot going on at your appointment. You are your most important advocate. It's important to know that there are 2 types of palliative care providers. These are called primary and specialty palliative care. Primary palliative care can be delivered by your own physician, treating any of your symptoms and addressing advanced care planning. Specialty or secondary palliative care is delivered by an interdisciplinary team of providers who have specialized training in palliative care. Optimal palliative care for patients with chronic lung disease should incorporate both primary and subspecialty palliative care. Remember, palliative care is an approach that improves the quality of life for patients and their families facing the problems associated with life-threatening illness. To find out more about palliative care, visit pulmonaryfibrosis.org.
So now we have to see, can we get out of here? Okay. Sorry for this, I'll do the quick. So that video is available on the Pulmonary Fibrosis Foundation site. They did a series of 12 videos to help patients learn more about their disease. And it's a good resource. If you don't have time in your practice, please direct your patients to it. So how do you find a palliative care? So these resources are available. So to find a non-hospital-based program, if you go to www.caringinfo.org, that will help. And then to find the nearest hospital-based palliative care program, it's this site, getpalliativecare.org, find a palliative care team. So I'd like to close with living well with IPF. We have a large support group at our center, and our mantra from day one is that we want our patients to achieve the best quality of life. This is a picture at our annual golf outing. So you'll see patients are here, they're wearing oxygen, they may not be on oxygen yet, but we make it a day that we close our clinic, everyone from our center comes. We have medical care for the patients. Our hospital DME donates the oxygen, and the patients just get to have a day to be able to get out and live with their disease. One of our research coordinators approached me a few years into it and said, well, you know, it's really not fair for the patients who don't golf. So I was like, well, what do you suggest? And she said, well, can we do an activity with them? I was, sure. So they now play bingo in the afternoon, and they have prizes, and the patients love it. And we have dinner at night and an auction. And the proceeds from this event actually fund our support group. So another activity will go in a few weeks. We take our patients on the Gateway Clipper. So if you're familiar with Pittsburgh, there's 3 rivers. So again, the whole idea is we want these patients to get out there and to live with their disease. And the very last patient. So the take-home message here, this is one of our patients. She learned that she got that she had IPF, and she walked out of the office, and she relates this after the fact to us. She said, I realized it was a bad thing, and there were a lot of things left on my list that I wanted to do. So she shared this picture with us. She traveled to Australia. Here she is wearing her oxygen, and she's dancing with the natives. So with that, thank you.
If you guys have any questions, feel free to come up and talk with us, or we appreciate you being here. Thank you. Hi. Oh, really?
I definitely had several patients
Oh, yeah.
who they're recommending starting on trials and neurology.
Very cool. How do you like Tucson?
Are you seeing that that's helpful?
No. Oh, yeah, that was a real small industrial place to come from. It's kind of heart of the earth. It's gorgeous. That's cool. Thanks for coming up. Hi. Good. Good to see you too. Yeah. How you doing?
House hunting, trying to find
You didn't find a place yet? Oh, I want an update when you find a place. Uh-huh. That would be great. I'd love it. Yeah.
Yeah, I'm kind of looking at Centennial.
Oh, yeah.